Well, good morning, everyone. I think everybody knows me. I'm here to introduce our speaker this morning. It is indeed a pleasure to introduce Dr. Jordan Greenbaum today. She's our speaker for Grand Rounds and in our series on trauma-informed care. Dr. Greenbaum has a fascinating story to tell. She is an adjunct assistant professor in the Department of Pediatrics at Emory University. And her clinical appointment, however, is the medical director for the Institute on Healthcare and Human Trafficking at the Stephanie V. Blank Center for Safe and Healthy Children's Healthcare of Atlanta. So those are her titles. That's what she does. But her story is interesting. Dr. Greenbaum is actually a pathologist. She's boarded in anatomical and forensic pathologists. It looks like in the 90s, she developed an interest in child abuse, particularly child sexual abuse, and since then has dedicated her career to working on this area. She has served on numerous national committees and also has been an advisor to many government committees to address this issue. She has spoken nationally, internationally, locally on this topic. And I have heard her speak once before. The talk was incredibly informative. It was fascinating, but it was chilling. So I will not hold her up anymore because we need to give her time to speak, but it is with great pleasure I introduce Dr. Greenbaum to you.
Thank you so very much for your extremely kind words. I appreciate it. And good morning, everyone. Happy Thursday. I'm going to talk a little bit about responding as healthcare providers, our response to human trafficking. Let's see, it's not moving. There we go. I have no financial disclosures or conflicts of interest. I'm hoping at the end of this talk that you'll be familiar with the definitions and the dynamics of human trafficking and exploitation, especially child trafficking, and be able to describe some strategies for identifying patients who may be at risk of trafficking or exploitation. And then we're going to talk about some common barriers to optimal care that have been reported by survivors of trafficking and ways that perhaps we as healthcare providers can use a trauma-informed approach, rights-based approach to overcome some of these barriers and provide optimal care for this very vulnerable population. Just to be very quick in kind of laying the groundwork, the federal definition for trafficking involves three components. You have to show an action, a means, and a purpose. So to say that this person or that person is a victim of severe forms of human trafficking, you have to show that at least one of the actions listed in the left-hand column has occurred using force or fraud or coercion, and the coercion can be something like blackmail or taking somebody's identification papers so they can't leave. It can be subtle or obvious for the purpose of exploitation. And basically this third column boils down to two types of exploitation: commercial sexual exploitation and forced labor. So there are two types of trafficking recognized by the federal government: trafficking for labor and trafficking for sex. Now, keep in mind that every state has somewhat very slightly different laws, and so they may interpret this federal definition in very slightly different ways, but they're all very similar based on this fundamental definition. And in all states, when we're talking about sex trafficking of a minor, anyone under 18 years, it is not necessary to demonstrate force or fraud or coercion. The mere fact of the child's age less than 18 means that anyone engaging that child in a commercial sex act, something where sex is exchanged for something of value, that is a situation of sex trafficking. So the child, for example, may think that they're consenting. I'm doing this for my boyfriend. He needs money, so I'm going to sell sex for my boyfriend. I've decided to do that for him because of my love of him. So this child thinks that she is consenting. However, she's under 18. She cannot legally consent to be exploited. Even if she's reached the age of consent for sex, whatever that is in states, 15, 16, she still can't consent to exploitation until she's 18. Let's take some examples. We're going to follow these people through the rest of the talk. So Hector, start with him. He's a 17-year-old male from a small, very poor, very rural village near Villanueva in Guatemala. He wants to migrate to the United States to find work, and his family is very eager to get him out of Guatemala, where there's a lot of community and gang violence. It's a dangerous place to be, and everyone is trying to leave. So he answers an ad from an employment agency in the newspaper, and they say, we can get you a job in Macon in construction, Macon, Georgia. And we will loan you $2,000 of US dollars, and then you can pay that back within 2 weeks, because the job we get you is going to be so lucrative that you won't have any problem paying us back. We'll get you the job, we'll get you an apartment, and you'll make this much money per hour. He gets here to Georgia, and he is doing construction. But now they say, you actually owe us $5,000, because there's all these hidden expenses. And the food you're eating today, we paid for that. So every day that you're here, we're paying for your food and lodging. You have to pay us. We're going to take that out of your pay. He works 14 to 16 hours, never sees a paycheck. He's a victim of labor trafficking. And then Pat is a 19-year-old transgender female who ran away from home when she was 15. She wanted to escape mom's drug addiction and the mother's violent boyfriend. So since the age of 15, she's been living on the streets and doing what so many runaway and homeless kids need to do, and exchange sex to pay for food, for shelter, for hormones. So when she was 15 and she was engaging in this survival sex, is what we call it, or transactional sex, she was a victim of sex trafficking, even though she would have been the first to tell you that nobody was, quote, forcing her to do this. But once she hit 18, she's an adult. Now there has to be force or fraud or coercion in order for her commercial sexual activity to be defined as sex trafficking. So if she were to go with a third-party trafficker, we should call pimp, for example, and he was forcing her to continue to do this, then she would be a victim of trafficking as an adult. And finally, Louisa is a 10-year-old female. Mother lost her job during COVID. She was working at a diner, got fired. The family's now facing eviction. So the mother tells Louisa, go with the landlord and do whatever he tells you to do. So once or twice a month, she goes to the landlord's apartment where he molests her, and he also has her pose naked and do sex acts in front of the webcam for people who are buying online time for live stream sex acts. So she is a victim of sex trafficking. All of these kids have a number of risk factors, and I think it helps to look at risk factors using a socio-ecological approach. So there are individual risk factors. For example, Hector is an unaccompanied minor. Pat is transgender. These are individual risk factors. They have relationship level risk factors. Pat's coming from a family of violence. Hector from a family of poverty, as well as Louisa. Hector is really essentially forced to migrate with everybody else in his little village because of poverty and violence. The community is very violent and with few resources for Hector and very few resources for Pat, who's living on the street, and for Louisa. And then finally, at the societal level, there are a lot of cultural practices that render certain large populations at risk. For example, gender bias makes women and girls vulnerable because they have limited opportunities. In some areas of the world, the gender bias is very significant, and that's a huge vulnerability factor. Xenophobia, homophobia, or sort of cultural practices that render people at risk. Well, how are children and youth recruited to labor or sex trafficking? Well, we've seen the fraudulent job offers from Hector and the false promises that are involved. And many areas of the world recruit people, including the United States, recruit people through these fraudulent employment agencies. Familial trafficking occurs. Parents, relatives may traffic others. Intimate partners may traffic their loved ones. This is happening with Louisa, for example. Smuggling can sometimes turn into trafficking. If I say I need to get into the country, I'm in Mexico, I need to go to the United States, I may think that I am being smuggled. I'm paying a, quote, coyote $200 to get me across the border, and that would be smuggling. If he takes me across the border, I give him the $200 and we each go our separate ways. That's smuggling. But it can turn into trafficking if that person says, now you owe me $500 and you're going to work for me until you pay that off. Now smuggling is turned into trafficking where the person is being exploited. Coercion and abduction certainly happens, but it is not the main type of recruitment technique, either in the United States or in most parts of the world, but it does happen. And once a child is recruited, how are they controlled? Why don't they just get up and leave? Well, we've alluded to this with Hector. Debt bondage is very common, and this has occurred with Hector, where he takes on a certain debt in the beginning, knowingly takes on debt, but then the circumstances of the debt evolve and are fraudulent and unfair, so that the situation is such that he can never get out of that debt. He can never get himself to the point where he's free. That's debt bondage, and that's a very powerful way of controlling people through economics. Confiscating identification papers, especially for immigrants, is one way to hold them, especially if Hector has a H-2 visa. It's a work visa, and it ties you to a certain employer, that construction company, so he cannot leave. If he leaves, his visa is invalid, and they have his passport, so he would be in danger if he left them. Threats and misinformation about what might happen, violence and psychological manipulation are very, very powerful. The landlord may be telling Louisa that this is all very normal, that all of his tenants do this. This is nothing to get upset about, so he's manipulating her. Certainly in false romance situations, psychological manipulation is a very strong control tactic. We know from a number of studies across the United States and some in Europe as well that trafficked persons tend to have access and do seek medical care. A couple of studies in the US showed very high rates of medical contact by victims. 83% of adolescents who are identified as trafficked in a Midwestern study were found to have been seen within that children's hospital system within the past year. Here in Atlanta, we did a study of adolescents who had been trafficked and saw that 43% of them had been seen at Children's Healthcare within the last 2 months before they were identified. And finally, in a very large study of adolescent females and adult females who were seeking services after their trafficking experiences, about 88% of them said they had seen a medical provider while they were being trafficked. Most of them had not been identified because for various reasons. Most of them went through hospital emergency departments or clinics, often outpatient clinics, teen clinics, public health clinics, reproductive health clinics, Planned Parenthood. But about a quarter of them saw their own physicians, be it an internist or a pediatrician or even a specialist. So really, whatever you're doing, wherever you are working in the medical profession, you're likely to have a patient who may have been trafficked. And there are lots of reasons why children will seek health care. Violence, as we know, is very common among both labor and sex trafficked persons. That may be violence at the hands of the trafficker, of a work manager, of a buyer, other people on the street. So violent injuries and trauma and assault are common. People may report to an emergency department with a history of acute sexual assault. And it's only after asking questions that you realize that this assault is occurring in the context of a much bigger chronic sexual assault in sex trafficking. Sexually transmitted infections are very common. In our study of adolescents, about 47% of them had an active STI at the time of identification as trafficked, and a third of those kids had a prior history of another infection. Pregnancy rates are very high among adolescent girls who are sex trafficked. 25-30% report a prior history of pregnancy. And finally, substance use is very, very common. In another study of adolescents who had been trafficked, about 47% of them fulfilled the criteria for a substance use disorder. And then finally, we're talking a lot about physical health implications, but the emotional impact can be just as devastating and harder to treat. Very high rates of post-traumatic stress disorder are seen among trafficked children, as high as 75% in some studies. And depression and suicidality are very common. So be very on the lookout if you have a child who has a history of major depression, self-harm, or comes in with a suicidal ideation. In one particular study, about 50% of trafficked children reported having attempted to commit suicide within the past year. So be very aware of that's a very common way that people can present with behavioral health issues. Well, how might Hector, Pat, and Louisa present for care? Well, there can be a variety of ways they might present. Pat, for example, may seek care at, let's say, a teen clinic or a federally qualified health center. She might come by herself, or she might come with other peers who are also living on the street, and everybody is looking for STI and HIV testing. Hector might come to an emergency department or urgent care for treatment of an injury. He might be allowed to come alone because the trafficker has brainwashed Hector and knows that he's too afraid to say anything about what's happening, so he can be trusted to be left alone with the healthcare provider. Or the trafficker may not trust him at all and may come with him and be the domineering presence of the accompanying person who wants to speak for Hector, control the situation, and get in and get out as fast as possible. Louisa is probably going to come with her mother, given her age, and she may come to her pediatrician or to urgent care, for example, for STI testing or behavioral issues, those kinds of things. But none of these children are likely to spontaneously disclose their exploitation. There are a number of reasons for this. I think one of the main reasons for kids is that in many cases they don't realize they're being exploited. Pat may be not realize that she's being exploited. She may feel that she's exploiting her buyers, that she is working the streets and getting the money that she needs to get and in control of the situation. She may not view this as exploitation at all. Louisa probably has no idea what's really happening. And Hector has no way of comparing his situation with the, quote, normal American labor standards. He may feel that this is the way work is in America, that everybody is treated this way, and this is just normal. So he's normalized his bad situation. In other cases, they may realize they're being exploited, but be very ashamed or feel very guilty or feel afraid of repercussions from the trafficker if they say anything, afraid of arrest and deportation, afraid of being identified and put into foster care. So there are all sorts of reasons why people may not disclose their exploitation. Now, the fact that they don't disclose it spontaneously doesn't mean that they're not necessarily willing to talk about it. And therein lies our opportunity to identify people who are at risk and offer services. But the onus is on us to figure out, well, who among all of our hundreds or thousands of patients are those at risk. And there may be some indicators that they're very nonspecific, but they may be the first clues to tell you that something is not quite right and maybe need to ask questions. In many cases, children who are trafficked by well-organized groups, criminal organized crime or gangs, for example, may be moved from site to site to site, one city to the next, especially in agriculture, forced labor in agriculture, or in sex trafficking. So they may not be familiar with the city where they are. When they come to see you, that may be, within 24 hours of them arriving at this city. They have no idea where they are, where they're staying. And that may be confusing to you and signal that something's not quite right. Many survivors say that when they've sought medical care, they've been accompanied by their trafficker who tries to control the situation, dominates the conversation, won't let the child talk, tries to answer all the questions for the child, and is very reluctant to leave the child alone for the exam. It may be that either the accompanying person or the child provides information that doesn't seem quite right to you, false demographic information, or a history to explain injuries or infections that just doesn't ring true to you. Something seems inconsistent. That might be your clue. Or it may be that they present with many of the health consequences known to be associated with labor and sex trafficking. So we talked a little bit about sexual assault and how that might be a trigger in your mind to ask questions about exploitation. Visible signs of abuse that you notice on physical exam, and these may be remote injuries, things that you associate with child abuse, loop marks, for example, cigarette burns, linear marks and scars, injuries to the neck from choking, those types of things should raise issues in your mind. A history of prior STIs or prior pregnancy, evidence of illicit drug use, especially intravenous drug use, all of these things may trigger in your mind the thought that these are associated with trafficking. Maybe I better ask a few more questions. Well, how do you do that? How do you ask more questions, and how do you work with a potentially trafficked patient? You're probably familiar with the trauma-informed approach to patient care, and this is, excuse me, it's a strategy. It's kind of a whole way of approaching people, not just in the healthcare sector. Other professionals use this, but it was described by the Substance Abuse and Mental Health Services Administration in 2014. It's called a trauma-informed approach to care. And basically, it is a whole way of interacting with your patients that rests on several sort of foundational tenets. One is that a trauma-informed clinician recognizes the impact of trauma on their patient and responds appropriately. So let's think about Pat for a second here. Pat has lived with trauma probably much of her life, with her violent mother's boyfriend, her issues struggling with gender identity, rejection. She's out on the street, so she's got all the trauma being out on the street. All that cumulative trauma has really affected the way that Pat sees herself, sees the world, and sees you, and interprets what you say, your facial expressions, and also affects Pat's behavior. And so it may be that that Pat engages in behavior that we may think is inappropriate. Drug use, for example, high-risk sexual behavior. She may be sort of hostile in our interaction with her. These are all reactions to her trauma. If we can recognize that as responses to a very traumatized life that this child has adjusted to. She's adapted to a very hostile situation, and her behavior, her attitudes reflect that adaptation of trauma. If we can recognize that, it's much easier for us to step back and be very non-judgmental and supportive rather than reacting to her hostility or being judgmental of her life on the street. So recognizing the impact of trauma and responding appropriately is really key to a trauma-informed approach. But also key is the real focus on psychological and physical safety of everybody, the patient and ourselves included, transparency, the basic human right of giving a patient information in a way that they can understand so they know what's going to be going on, respect and empowerment. So think about the ways that a child, any patient, may be subjected to situations that may be very triggering just in the normal course of a medical encounter in your clinic or in the hospital, in the emergency department. Think about the process from check-in and registration to discharge, how there may be situations in which any child may feel uncertain about what's going to happen. They may feel like they have no control over the situation. Some places they may feel threatened or even coerced. Is there anything that they experience in the situation of your visit that may be an experience of shame for them or make them feel vulnerable? Well, chances are there are these situations that we just don't think about. But if you think about, say, Pat coming into a situation, a clinic where she's never been to your clinic before, she doesn't know, she knows she wants to get STI testing, but she doesn't know exactly what's going to happen. She's sitting there in the waiting room. She's afraid. She doesn't feel like she has control. She's used to physicians and nurse practitioners telling her what they're going to do and sort of taking control of the situation. So she feels this lack of control. She's feeling very vulnerable. If you say to her, we're going to get some blood work done, so we're going to take a blood sample, she's thinking, what the heck? That's holy smokes, you're going to get blood from me? Is this some kind of vampire thing? So she's threatened. Maybe she feels coerced. These are all things that she may interpret as being very triggering and bring back all the memories of these emotions that are tightly associated with her trafficking. She often feels uncertain and out of control when she's with a sex buyer. She may feel shame. She may feel coerced. And inasmuch as her experience with healthcare providers triggers some of those same feelings, it can be very anxiety producing and sort of be very what we call triggering. So how can we minimize these potential trauma triggers? We don't want her to be any more traumatized through this medical visit than she already has been in her life. How can you do that? Well, the trauma-informed approach can really address all those issues. We can start by demonstrating respect and provide explanations, make it clear what is going to happen, and sort of take away some of that uncertainty and that lack of control. So I might say to Pat, I might say, introduce myself and ask her what she would like to be called. I wouldn't say, gee, your name is Patrick in the medical record. Is that you? Are you Patrick? Instead say, I'm Dr. Greenbaum. What should I call you? What would you like to be called? Pat. Okay, Pat, let's talk about this. It sounds like you're here for some STI testing, but I've never seen you before, but I'm really glad you're here. So you haven't been to this clinic before. What were you anticipating when you were coming here this morning? How did you feel about this? How do you feel right now? You're acknowledging perhaps her anxiety, getting a sense of what she's expecting, maybe some uncertainty. She probably says, well, I didn't really know what to expect, but I want some testing done, so I don't really know. Well, let's take away some of that uncertainty. Let's just talk about what can happen. This is going to be a visit that's very much about you, Pat. We're going to talk about what you want, what you need. So we're going to work together to figure out what you need. But I'm going to explain as much as I can as we go along so that you know what's happening and you can make choices. There you go. You've addressed her uncertainty, her lack of control. You've given her respect. She's no longer feeling ashamed. She feels very empowered. And we're maintaining transparency. And we're getting her consent. Well, a big thing about trauma-informed care is that it's very strength-based, and it took me a long time to figure this out. I always thought about trauma-informed care as being a way to treat, sort of with kid gloves, a victim. This person's been victimized. How are you gonna treat them with kid gloves? But it's much more than that. It's very strength-based. And part of it is really building on the resilience of your patient and trying to empower them so that they get some of that self-agency back that they didn't have while they were being trafficked. So ways to empower a child are to offer choices and control through the whole consent process, for one thing, but also every little thing that you can think of that you can offer them a choice, do it. For example, when you come in, when you bring Pat into the exam room, offer her the opportunity. You want to sit in the exam table, you want to sit in the chair. You don't care where she sits, so she gets to choose that. Would you like a blanket? Are you cold? Would you like something to drink? These are all choices, and it makes her feel comfortable and in control. We can start by saying, the reason I want to ask these questions is yada, yada, yada. Is it okay? You don't have to answer these questions. You can answer some or not. Is it okay if I ask you questions? You're giving them control. When you explain the limits of confidentiality, that's a little bit confusing to a child. So you may get to the end of that and say, I've said a lot just now. Do you have any questions about that? You're encouraging them to be engaged. We need to recognize their role as experts, and this really becomes important at the end of the visit. When you've gathered a lot of information, you have in your mind, okay, I need to recommend A, B, and C, homeless shelter, contraception, this and that, this kind of testing. You got it all in your mind, you got it all organized. But before you say this is what we want to do, instead say, what do you think would be helpful for you when you leave here? What is the best thing that we can do to help you? So you're recognizing that Pat or Louisa or Hector is the expert on themselves. They know their lives better than we do. What do they think would be helpful? And then you can say, we've talked a lot, we've got a lot of information. I really appreciate you being so open with me. What you've told me makes me think of a few things that might be of help. Would you like to hear them? Again, giving them control. Well, of course they're going to say, yes, I want to hear them. Then you can roll out your ideas and say, it sounds like you're living on the street, Pat. It sounds like you might need a shelter. Are you aware of this place called Covenant House or whatever, Hoo-Ha House, whatever it is, whatever it is. Yes, I'm familiar with it, or no. Would you like to hear a little bit about it? Or here's a flyer about it. And then focus on their ability to say what they know about it and their strength and their knowledge of what's good for them. Bias and discrimination has received a great deal of attention, especially over the last year, and I think it's really worth talking more about that today, because if you think about it, people who are trafficked, be they labor trafficked or sex trafficked persons, often face bias and discrimination at multiple levels, not simply because they are being trafficked. There's a whole, quote, prostitution stigma that goes along with being sex trafficked, and Pat is all too aware of the bias and discrimination of that. But there are other levels of discrimination. For example, Pat is transgender, so there's the whole stigma against that she probably feels and experiences all the time. Hector, foreign born, there's a xenophobic bias and discrimination that he experiences. Low socioeconomic status, being runaway or homeless. So kids, Pat, Louisa, and Hector are experiencing bias and discrimination from all sorts of levels based on race, ethnicity, country of origin, social status, etc. And we have to be really aware of that because it can be an overwhelming source of trauma for them. And it's really important for us as healthcare providers to be aware of our surroundings and be aware of any situation in the healthcare setting where you identify bias or discrimination. We cannot be passive bystanders. If you notice somebody say something either to a child or to somebody else about a child, and there shows some bias and discrimination, we need to step up and say, that's really just not appropriate, and be active in combating that and fostering an environment where there is zero tolerance for bias and discrimination. And that involves thinking about our own implicit biases. I may have my own feelings about I don't know, runaway homeless kids or whatever, LGBT. I may have my own feelings about that. I need to identify them and make sure that whatever bias I have, I leave at the door when I'm interacting with my patients. Let's talk a little bit about identifying patients at risk. We've talked about some of the indicators, and again, those are kind of soft indicators. They're fairly non-specific. A lot of kids may not have those indicators. So often we're going to want to screen if you can. And there are very few clinically validated screening tools for adolescent sex and labor trafficking that have been designed for the healthcare setting. But whatever questions you use, even if you make up your own questions, keep in mind that a screening process, the end goal is not to get a disclosure of trafficking. You're not going to pester Hector or Louisa or Pat till they finally say, okay, he paid me $50 for a blowjob, or I can't leave, he's got my passport and I can't leave, I'm being labor trafficked. For one thing, these kids don't understand that. They don't understand what exploitation is meaning, and it's very traumatizing to push and push and push until you get Pat to say, yes, somebody paid me for sex. That's just counterproductive. It can be traumatic for the child, and we don't need to do it. Our goal instead of trying to identify whether they meet the federal criteria for trafficking, is to sit back and assess the level of risk. Is Pat at risk for being sex trafficked? When she's 15, living on the streets, you bet she is. If somebody says, I've run away from home, that in itself makes them at risk for exploitation, unless they say, well, I ran away from home, but only for 2 hours. I went to my aunt's house. I was mad at my mom, and then I came home for dinner. That may be their idea of running away, but it's not particularly high risk. So our questions are designed to assess the level of risk. How concerned are we? Do we reach the level of reasonable suspicion that this child is being trafficked? And if so, then we make the report. So we're assessing we do not need to be certain that somebody's been trafficked. We need to assess our level of concern and respond appropriately. And the other thing, the reason for screening is to identify the risk factors that make this child vulnerable so that we can address those specific risk factors. So there's a screen for child sex trafficking that's been designed and validated in multiple healthcare settings, the emergency department, teen clinics, and child advocacy centers so far. It's a 6-item screen, and it screens for child sex trafficking. It does not screen for labor trafficking. That basically, the child can fill out a form either on an iPad or on a written piece of paper, or a person can ask the child these 6 questions. And if they answer affirmatively to at least 2 questions, then they, quote, screen positive. And the number of sex partners greater than 5 counts as a positive, a yes for that question. Screening positive does not mean that somebody's being trafficked. It means they're at risk. And so you would follow up and say, we need to assess the level of risk. Remember, we're assessing whether this is something to be concerned about or not. So you follow up with questions, open-ended questions about all the affirmative questions from the screen. Pat, you mentioned that you have run away from home. Can you tell me a little bit about the last time you ran away from home? You're opening up the discussion to find out, was it for 2 hours or 2 weeks? Was the child, what did the child do to get money? Where did they stay? Who did they meet? Those kinds of things. How did they feel? Tells you whether this is a high-risk situation. And then you may also want to ask more pointed questions depending on the rapport you have with your patient and their level of comfort. Have you ever been in the position where you've had to consider exchanging sex for something you need? I see a lot of kids who live on the street, and many of them have very few resources, no money. And some of them tell me they have to end up exchanging sex just to get what they need. Have you ever been in a situation like that? I'm not saying, Pat, have you ever done it? I'm saying, have you ever been in a situation where you've had to think about that? And if Pat says, yes, but I didn't ever do it, the fact that she said yes makes me very concerned and puts her at very high risk. Has anyone ever asked you to have sex with somebody else? Not that person, but somebody else. That's a very high-risk situation. So in these open-ended questions, you're sort of probing a little bit more to follow up and find out whether the vulnerabilities are major vulnerabilities or minor. And if you get that reasonable suspicion that Pat or Louisa or Hector is being trafficked, then you move from there. There are also tools for adults. This one is designed and used in the healthcare setting. It has not been formally clinically validated, but it consists of 8 questions, tests for labor and sex trafficking, and it can be used for, say, teen parents. So maybe the parent who is your patient's parent is the one who's being trafficked, in case you need that, if you're treating people who are over 18. In many cases, if you don't have a screening tool, or you don't, for some reason, you're not going to be screening, another way of providing help is to use universal education and resources. And this involves usually about 5 minutes, in which every patient gets about a 5-minute blurb where the clinician or somebody, maybe you, maybe one of your support staff, sits down and talks with them, the patient, about healthy relationships, about the impact of violence on health. Starts to introduce harm reduction techniques and maybe introduces the idea of what human trafficking is, and then offers a little resource. This is like a little tiny brochure from Futures Without Violence that talks about healthy relationships and provides community resources and national resources. You're not asking the child or the teen whether they've been exploited. You're saying, this is common in our world. Violence is common, exploitation is common. Here are some resources if you think this might apply to you or one of your friends. And then you leave the door open. If they want to say, wow, I do want to talk about this, then you talk about it. But you're not actively screening them. You're providing them with resources. And for LGBTQ youth, there's a different resource for staying safe and seeking support. So this is another way that you can provide information resources to your patient. I think personally that the best thing is to provide this universal education and the screening tool so that you're giving information and also screening for individual risk factors. Know your mandated reporting laws I think in all 50 states now, we're mandated reporters for suspected sex trafficking. It's looked at as a form of sexual abuse. So know your mandated reporting laws and who you need to call. But be very transparent with your patient about the need to report. We should never just make the report without the patient's knowledge, because that's total betrayal, and they've been betrayed by a lot of people. We don't want to add to that. So it's important to say let's say Pat again. Let's pretend Pat's 15 and she's not 19 now. She's 15. Pat, a lot of what we've talked about has made me really concerned about your safety and your health and well-being. I'm really concerned about people potentially taking advantage of you and wanting to harm you. Because of my concern, I'm going to need to make a report. I'm obligated to make a report, and I need to call the police or Child Protective Services, whatever your mandated report is. And the reason for that is because I'm concerned for your safety. I need to let them know so they can help me to help you. Now, Pat's probably going to go through the roof because she's been through foster care once or twice, and she may be very upset. What do? You say, let's talk about that, Pat. What is it that really makes you upset about the idea of me talking to the police? And she goes on. She tells you all about it. Do what you can to address her concerns, but the bottom line is you're going to need to make the report anyway. You need to make that clear. But while you can't give her that choice on that, you can give her choice and control in other ways. You can say, I need to make the report, but you and I have control over how that's done. Would you like me to make the report on my own? I can go to my office and make the call, or would you like to make it with me? We can sit here, we can use my speakerphone. You can be on the phone and talk to Child Protective Services too. It's giving her control, giving her some sense of control over the process. And then if she says, well, if you go, you can go make that report, but I'm leaving and I won't be here when you get back. We can't make her stay. We can't force her to stay, but we can say, you can do that. But before you go, can we talk about referrals and resources so that at least you have that before you go? I can't stop you. And if you go, I'm still going to have to make the report. But let's talk about resources. And use the information you've gathered in your long talk with her to figure out what she needs, and then ask her what she thinks would be helpful, then lay out what you think would be helpful, and talk about it. Make a safety plan for her that she can live with. For any referrals that are not mandated, you need to have Pat or Louise or Hector's consent. So we need to respect their privacy. If you have a reporting procedure in your area, and you probably do, use that reporting procedure. If you move somewhere else, you're not sure what the resources are, what to do in your new job, you can call the National Human Trafficking Resource Center anywhere in the United States. You can call this 24-hour hotline and report concerns about trafficking. You can get information about the questions you might need to ask. You can get information about resources in that area. There's this huge database that'll give you resources. You may be in Podunk, Iowa, but they will say, okay, in Podunk, Iowa, there's a homeless shelter within 5 miles of your hospital. There's a anti-trafficking organization and a task force that can help you. So they can plug you into resources. They can also talk to patients if the patient allows that, allows the sharing of information. So they're a very good resource. I'd like to just end by just offering some resources. If you're interested in this topic and want to learn more, there's the opportunity to get resources from the Institute on Healthcare and Human Trafficking, which is an online institute that is designed to provide resources for medical and mental health providers who may see adult or pediatric victims of trafficking, either labor or sex trafficking. So if you go to this website, it provides a lot of ongoing new information, for example, new ICD codes with human trafficking, the intersection of trafficking with the COVID-19 pandemic. So there's updates and things that change over time. And then there are ongoing resources that are updated periodically. If you click on any of these light green boxes, it'll take you to a list of research articles that can give you more information on these various types of trafficking. And so they're good to learn more. If you go under healthcare protocols and guidelines, that's one of the boxes, it'll give you the screening tools that we talked about, the adolescent one and the adult one. You can get those screening tools. It'll give you other guidelines for developing a protocol in your hospital or clinic, and a lot of resources for you and your staff. We also have resources for families. And finally, the Institute, because we're grant funded, allows me to provide technical assistance if you at your hospital or your clinic want to develop guidelines so that the staff have a clear picture of exactly what they need to do, what they need to look for, who they need to call, the process, the outline of the flow diagram of how they respond to suspected trafficking. I can help you write those and tailor them for your particular program. We have a lot of samples of guidelines, but you're going to want to design ones that are particular to your own setting. So I can help you do that if you're interested. So that, again, is the Institute on Healthcare and Human Trafficking. So just to conclude, I think a trauma-informed, victim-centered approach is really going to go a long way in helping us to build sort of a safe environment for trafficked patients to feel like they can, if they want, talk to us about what they need and allow us into their private lives so we can offer resources. And in many cases, especially working with children, when you have a lot of mandatory reporting requirements and you're concerned about this and that's Child Protective Services and the police and it's very hard sometimes to decide what to do. And you may feel at wit's end thinking, I'm not sure what to do. If I call the police, it may make it worse. Shall I do this? Shall I do that? What I find when I'm in those situations is to step back, take a deep breath and say, okay, what is ultimately in the best interest of my patient? Their basic human rights, their best interest has to take top priority over anybody else. So if we can sort of step back and go look at it through that lens, I think that can give us some guidance. But ultimately, we need to be flexible. We need to listen to our patient and learn from them, follow their lead, allow them to tell us if they're ready, offer services, but if they're not ready to accept them, that's fine. Leave the door open. They know they can come back. That's really the ultimate message. And I think we're supposed to come up with an audience question. So here's our audience question. The main goal of screening for child trafficking is to, 1, fulfill the Joint Commission requirements. 2, B, determine whether the child meets legal criteria. C, assess the level of risk for trafficking and identify patient needs. Or D, determine whether the child may be suicidal. So please type into the chat box what you think the answer is. Yeah, I think it's pretty solidly C, absolutely. I'm so glad you did that. Thank you. Yes, assess the level of risk for trafficking and identify patient needs. That's it. You win. This is great. All right, this is the end, and I'm going to open it up for questions. I hope if you have questions or anecdotes or thoughts, please share them because we can all learn. This is where I learn the most. So please chat in the box if you have questions or want to say something. While you're thinking of questions, one of the things that comes up a lot is that we as healthcare providers, we've been trained, to kind of come in and fix things. We're fixers. If you've got a cold, we'll give you something. If you got it's illness, we're going to treat it. You got a broken leg, we're going to fix it. And it's really hard to work in this situation because we're not here to fix the situation for these kids. We're not able to, quote, rescue them, even though a lot of, the public will look at it as rescuing kids. We're not rescuing them. We are offering help and trying to support, but we cannot fix things. In most cases, children who have been trafficked, even if they're recognized and put into residential treatment centers and get a lot of help from Child Protective Services and other NGOs, many of them will go back into the trafficking situation once, twice, 3 times chronically. It's almost like an intimate partner violence relationship. It's a cyclical thing. And so we have to take the long-term view on this. We can't assume that we're going to fix it, they're going to go away, and their life's going to be joyful from here on out. It probably won't be. We have to just sort of have lower expectations and say, what can we offer? We've built a little bit of trust. The expectation is we've built trust, and that next time it might be easier for Pat or Louisa to come back and open up a little bit more. And 2 years from now, Pat may be able to extricate herself from this. So we're not rescuing, but we are offering hope, offering services, offering support. And I think that's a huge thing. Okay, here's one. We have a very large homeless shelter in Roanoke, and I was wondering if these facilities tend to increase rates of trafficking due to large at-risk populations, or decrease rates due to having an alternative to being on the streets. That is such a great question. Thank you for that question. There's some evidence, and there are lots of homeless runaway studies, and looking at exploitation among children who are living street-based youth. There's at least one study showed that kids who are living in a shelter are less likely than kids living on the streets to be sexually exploited, engaging in transactional sex. The rates were like 9.5% for those living in shelters and about 28% for those living on the streets, which would suggest there's a sort of a protective aspect of that, which is intuitively makes sense. I do agree with you, though, that when you have a lot of people in a closely filled situation, there's nothing to stop that type of recruitment. And in fact, juvenile justice centers are prime areas of recruitment. Even residential treatment centers for children who have been sex trafficked are sometimes the kids who are enrolled there are subjected to recruitment by other kids there. So yes, there is always that concern, but there's also the protective factor of having your basic needs met by the shelter. So, which one wins, it probably depends on the situation. It's a really good question. And the rates of transactional sex among the homeless street-based youth is anywhere from 16 to 45%, depending on the studies you look at. Very, very common because people are so desperate.
Dr. Greenbaum, your previous talk that I heard, you contrasted the presentation for a female who's being sex trafficked to a male. Can you briefly talk about that for a minute?
Yeah, thanks for bringing that up. Most of the research and most of our public services focus on female sex trafficked females. That's kind of where we all focus. But we tend to ignore the fact that many boys, many transgender youth are sex trafficked and labor trafficked as well. There are many overlapping risk factors. If you look at studies of boys and transgender youth, the risk factors of abuse and neglect, dysfunctional homes, those kinds of prior sexual abuse are the same. Risk factors are the same, but there are other ones as well. Transgender kids have all the risk factors associated with being ostracized and discriminated against, add to their vulnerability. Boys are very much at risk, and if you look at the homeless runaway studies, boys are often have a higher prevalence of commercial sexual exploitation than girls in many studies. There's some indication that they may be even less likely than girls to disclose their exploitation, probably related to the societal expectations for gender roles. Boys are strong, they're supported, they're leaders, they cannot be victimized, they can't allow themselves to be victimized, and if they are, then that must mean they're weak. So that whole sort of gender role and expectation makes it very hard for a boy to recognize themselves as being exploited and out of control. And it makes it hard for other people to see that. If we don't tend to look at boys as being vulnerable to trafficking, we don't screen for it, we look right past it, and even if it's right in front of us. So they're less likely to be identified and may experience more shame than girls because that added gender expectation rules for that as well. But they do have extremely important needs, just like the girls do. There's also a couple of other things about boys. What we know about them is they're less likely to be controlled by a third party, what we used to call a pimp. They're more likely to work on their own if they're working on the street or with peers. And that may be another reason why we not focus on boys, is because we usually think of trafficking as involving this sort of pimp-based trafficking, and that's not as common with boys. It's more of a survival sex. Thanks for having me. I really appreciate it. Thank you. And if you want to reach out anytime, please feel free to email me at my email address, or you can also contact me through the Institute website.
All right.
Thank you so much.